Yeah. Good morning, everybody, and welcome to this meeting of the Health Scrutiny Committee, which is being broadcast live. Please note that we will adjourn the meeting and pause the broadcast at 10:45 to enable members to attend the Armistice Day ceremony, and we will reconvene immediately following the ceremony. Item 1, minutes of the last meeting held on the 23rd of September 2025. Has everybody seen the minutes? Yeah. And has anybody got anything from those minutes, or can I accept those minutes as a true and accurate record? Yeah. Okay, accepted. Item 2, apologies for absence. James, do we have any apologies?
So, Chair, we have received apologies from Councillor Alan White for other reasons, and we've also received apologies from Councillor Helen Faccio for other reasons, and attending as a substitute for Councillor Faccio is Councillor Penny Garland. Thank you, Chairman.
Thank you, James. Item 3, declarations of interest. Do any members present have any disclosable pecuniary interest to declare? No. And do any members present have any private interests, pecuniary or non-pecuniary, to declare? No. Okay, thank you. So we'll move on to item 4, which is our first item of discussion. So the next item is a consideration of the report from the Integrated Care Board, which outlines the progress with the recent change of provider for Nottinghamshire's community gynaecology service. I would like to welcome representatives of the ICB, Gemma Weissel, Deputy Chief Delivery Officer, and Dr. Nicola J, Deputy Medical Director. Would you like to introduce the report, please?
Well, thank you. Morning, everyone. So I'll just give you a brief overview of the report and then open up for questions if that's okay. We previously had a community gynaecology service. This was for residents in the city. Today we're talking about the south of Nottinghamshire. This was provided by PICS. And this was PICS served notice on the end of this contract, which was, so it wasn't a decision taken by the ICB, it was a contract that was handed back by the service provider. What I'm going to take, is to just give you a brief overview of the provision in the other areas across Nottinghamshire. So you can see from the report that in mid-Nots, what we had was a Gynaecology Plus service that offered some of the same gynecological services in mid-Nots only. And then whilst this was in operation, we didn't have a community gynae service provider in Bassett Law. Since this has happened, what we've done is to mobilise the same offer that we had in mid-Nots across South Nottinghamshire and Bassett Law. So actually now all of our residents have access to that Gynaecology Plus model, which focuses on polyp removal and pessaries. And what we've done in there is to just talk about what happened. By working with primary care, we had a fantastic response from primary care colleagues, and we're able to mobilise an additional 29 practices who didn't have to provide this, but actually wanted to be part of the community gynae offer. So they have now mobilised and are seeing patients for pessaries and polyps. What we've also done, because with gynae, there is obviously those patients that are being referred and need treatment, and those that have had treatment and require a follow-up. So for those that have had treatment, we have commissioned Modality, who are providing a clinical overview of those patients. So they're able to look at the treatment, look at the notes and decide on next steps. And obviously as an ICB, that isn't something that we can do. So we have got Modality working with us to undertake that work. I guess in terms of the broader context, just to give you a picture of where we're going next. This is an interim solution at the moment, and what we are doing is in line with the Women's Health Strategy and the 10-year plan. We are undertaking a period of engagement and co-design about what we want our gynaecology services to look like in the future. We're working with colleagues at Nottinghamshire County Council and Public Health to jointly commission COIL services for women, and looking at things like shared care protocols, referral guidelines, so that we can make it as easy as possible for patients who need gynaecology to be seen as close to home as possible. So what we want to do is avoid them going to an acute hospital if they don't need to. So that work is underway at the moment, and what we want to do is build on this as an opportunity to say actually it gives us more provision closer to home for people, and so broadly in line with the women's health strategy. So that was all I was going to say, Chair, as an introduction.
No, thank you, Gemma, for your introduction. I'll now open the discussion for members. Councillor Dodd.
Hi, as a County Councillor from Bassetlaw, I'd be pleased if you could share with me the 4 practices that have signed up to this, please.
I'm sorry. I'll get that during the meeting. I have got that, but not in the report.
Okay, thank you.
Any supplementary questions, Councillor Dodd? No? Councillor Cox.
Good morning, thank you. I've just got one quick question. 25 practices across Nottingham City and South and Notts, 4 practices Bassetlaw. Is there anything covered in the North Notts area, the Ashfield area?
So what we have got, so we have 29 existing, and then we've got an additional 29. So if it would be helpful to the committee, what we can do is to provide that full list. Would that be helpful? I'm conscious all members will have an interest. If that's helpful, we can do a full list.
Yeah, that's great. It's just obviously no mention of the sort of the North Notts area. That's all. So that we're not being missed off the list. That's all.
Councillor Gowland.
Thank you. I don't really know much about how the NHS is organised. I was a little bit concerned about the discussion about follow-up care. Because to the layperson, it sounds a bit unjoined up, that having sort of separate group come in and look at the notes and decide. Can you just elaborate on that, please?
Yeah, so it's so post-treatment, it will always be somebody's review of the notes to decide what next. So many of those patients will be discharged back to their GPs, but it's if they need something else following treatment that then it requires a clinician to look at those notes and decide what next. Yeah. So it's more depending on the individual patient and their potentially their individual long-term health conditions that they might have anyway. About so what happens next? Are they okay to go back to primary care? Are they okay to be discharged, or is there something else that they need? So we've just got some clinical support, making sure that all of those outcomes are right for patients.
As a patient, I think you just understand why the original tertiary care clinic went to the very first then. It just seems a little bit of a convoluted way of getting around things.
I think so. Ideally, when you're seen by a clinician, it will be that same clinician who would make a plan for you and decide whether you remain in the service or whether you're discharged or not. Unfortunately, with PICS withdrawing from the contract, there wasn't that opportunity for that clinical review to happen. So what we've done as an ICB is we felt that we didn't have that internal ability to do that ourselves. We've commissioned external support from clinicians who have experience within the specialty to look through the women's notes to say what happens next for them. So this isn't ideal, but within the NHS at the moment, what frequently happens is you're not seen by the same clinician at follow-ups. Even within my own service, ideally the patient should be seen by me, but unfortunately, because of pressure on time, that doesn't happen all the time. So this is the best fit that we have currently for these women.
Councillor Cox.
Just a quick one, sorry. PICS, are they still contracted to anything to do with us at all in the county?
Yes, so they provide a range of services. At the moment, from an ICB perspective, they also provide MSK and pain services, but obviously not gynae anymore.
So why did they hand the contract back? Was it lack of funding, or what was the reason for them handing that contract back to us?
There were a whole range of reasons involved in them handing back the contract, and obviously for them as a provider, they have to make that decision. So they made that decision and handed the contract back. So the ICB response then is to respond to that end of the contract.
Hopefully it's not a cherry picking that they picked out the best and give back the hardship. I mean, are they, when they gave it back, they didn't give it back because it was too much of an hassle, so I'm assuming, and that, you know, that they are providing a reasonable service for the other project or the contracts they've got with us.
So when the PICS service contract was first initiated for gynae, then there's a certain model of care that was expected for them to deliver, which was very much a primary care offer. So the kind of model that they had was that the GPs, the main, would be providing the service with some obstetric or gynaecology oversight to that service. But unfortunately, what happened when the service actually developed, and this might partly be due to COVID, so during COVID things happened that we kind of weren't intending to happen, and the contract for this service started in 2019, so its first year was 2020. So when the actual contract was delivered, what happened was it became a gynaecology delivered service, which made it far more expensive. So when PICS wanted to continue with that model, the funding that was initiated wasn't enough to cover that contract. But the work that needed to be delivered didn't need to be delivered by gynecologists. It needed to be delivered by primary care. And very much the direction of travel of the NHS is if primary care and GPs can offer a service, they should be offering a service. But with that extra layer of having a gynaecologist available for the most complex states to understand where they can be moved to. So that's the model that we want to have across the whole of Nottinghamshire and Nottingham City for an equitable approach for patients. And unfortunately, that's not the model that PICS wanted to deliver. So they very sadly withdrew from the contract.
So forgive me then, I'm just struggling to understand that how they mid-contract can change the contract layout.
So it happened over COVID, we think. So the initial model of care that was expected was that it would be a primary care delivered service with gynaecology, MDT and oversight. But during COVID, many things happened unintentionally because actually you didn't have the offer that was initially initiated. So GPs were pulled in many different directions. You couldn't get the education and training for things. You couldn't actually have the time to deliver that service. So what evolved was different from what was initially set out. And despite attempts to correct that over quite a number of years, that didn't happen. And over that time period as well, what's happened is the NHS has very much moved into a direction of travel, which is having that primary care offer, not the secondary care offer, because that's what we want for patients, is that closer to home offer that we need. So unfortunately, that couldn't then be worked through, but PICS decided to withdraw from the contract.
Thank you.
Councillor Barlow.
Good morning, thank you. Obviously, it's great that the GP practices have obviously agreed to take this on. However, GP practices are already pushed to the limit. Are we sure that they can deliver this service?
So this was a voluntary ask that GPs can sign up, and I think it's very much in line with other services that we've got. If GPs want to sign up to additional, it's a local arrangement that we have. They demonstrate how they will deliver those services, when they'll deliver the clinics, and obviously they get a blanket payment for doing that. But it's very much an ask of primary care, and they volunteer to sign up. And so far, everything is going well with this. So absolutely agree that primary care is stretched, but it's an ask of GPs to take on additional services. It's up to them if they want to volunteer.
Councillor Cox, again.
Yeah, sorry. You just raised another question for me there. So they get the GP get a financial incentive to sign up to this project. What are we doing to monitor that they're actually fulfilling that agreement, not just signing up to get the extra funding?
So it's very much paid on actual clinics and actual patients that they see. So it's not a blanket payment that they receive. It's based on delivery of that service.
And how are we monitoring that?
So we will send the patients. So So within the ICB, we've got a referral support service that we reference in the paper, and at the moment, the referral support service is holding those patients and booking those into clinics and appointments in acute care as well.
Okay, and I'm just obviously worried because as right point out,
Can I just say, let's just make it this last one because I've got other members that want
yeah,
to
yeah,
come
no, sorry. I'm just concerned that we're overloading the GP practices because, as we all know, it's a struggle to get a GP appointment as it is. So that was just my concern. That's all. Thank you. I'm done.
I'm sure. Councillor Wheeler.
Yeah, thank you, Chairman. My question's gone on for the last two really. It's just about it's about GP service volunteering. Obviously, they're volunteering for a reason. They're getting paid for it, which I think yes, I know that's a model we have. But my concern is it may be more profitable for them to do this kind of service rather than the day-to-day service they provide there. How are we monitoring to make sure that these practices who are signing up for this are not then effectively pushing out patients who are trying to get appointment from? So we all have that. We've got residents contacted who can't get appointments. My own brother member tried to get an appointment the other day and was told it's 2 weeks, so he'd have to go to the walking centre. So I just know that from own experience got at the moment. So it's just out of knowing that we are not just relying on the GP practice to do that service and we're just pushing the problem of perhaps day-to-day issue we will be dealing with to walking centres and other places. Really, that's just my concern with some moving around an issue rather than trying to solve. So we need to know what the long-term plan is in place. I know it's mentioned about more going to primary care, we can understand, but we just need to make sure the capacity is there and that's been planned for with new housing developments, expanding practice, etc., to make sure that can be managed. Because as I say, that's my concern that we are just going to have an issue where people can't get all standard practice at these appointments. Thank you.
Yeah, so we have a whole regime around performance management of primary care. So we make sure there are two streams. So there's the urgent and then there's the planned, and this very much would sit within the plan. So the planned clinics on planned days. But absolutely take the point, and there are very much two streams. We are working very closely with primary care on availability of appointments, both in the urgent and planned. So it is a balance between the two. But there is a whole architecture around how we monitor that as an ICB together with primary care.
The other thing as well is because they're getting paid more money, actually much of this service and offer is delivered not just by GP but by nursing staff. So they're well within their rights to employ more staff to be able to do this planned care activity. And if what we want to see is a shift from hospital to community, we have to do that. We have to encourage that. So members of staff that currently exist in different places, we need them in the right place rather than the wrong place. And that funding shift helps to enable that to happen as well.
Councillor Gowland.
Sorry.
No, you're not welcome.
Which raises the question, is this delivered by, what aspects is this delivered by doctors, what by nursing, what by people like physicians associates?
So there'll be a mix of that depending on the need. So very much so. Some of this will be GP delivered, some of this will be nursing staff delivered, depending on the complexity of the patients. So it's not a one-size-fits-all model. It's about who has the right skills to actually be able to deliver the service that's required, and that's what we're looking at across all of these kind of elements.
Councillor Wright.
Yeah, what concerns or challenges do you think this faces in the next 12 months?
I think for now it's getting through the patients that need to be seen, and so we've had a backlog. The right approach is to manage that backlog and to actually deliver, to make sure we deliver on the promise to get those women seen in services. As Gemma rightly said, again, we have the women's strategy. We've got the development of the Women's Alliance to make sure that we aren't in this situation again. We need to make strong links with our kind of county public health, our city public health. We need to have pre-referral guidelines in place. We need to have referral guidelines in place. We need to make sure that actually for women across the entire system, we have the right health services to deliver what they require.
And you're pretty confident, it's only weak spots that there or?
Well, weak spots are always funding, aren't they? If we're honest. And so actually when you're delivering anything that's kind of what we want to do is about prioritisation. And so we're prioritising the needs of these women, and then we'll prioritise the next step in terms of what the the future health looks like and future health requirements look like. And so I think that the weak spot is always going to be funding or any around any of the service delivery. And that's why, really importantly, we need to join up with our public health teams to make sure that we have that commissioning arrangements for all of the women's stuff that is effective as well.
Okay, thank you.
Councillor Barlow?
I think yes. Obviously, another concern is, and I'm sure you must consider this to be a problem, is women quite often aren't taken seriously, are they? You know, when you see the advertisements on the television, oh, you know, you're just a woman, blah, 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 you know, it's all in your head, or that sort of thing. What are you doing to overcome that?
So I think that's about raising women's voices. Very personal story. Last year I had pancreatic cancer. I was told it was menopausal symptoms. And so I think that actually, as somebody who's advocating for women, I think it's quite a strong position to make sure women's voices are heard. You're right, so in terms of what kind of happens to women, the symptoms are often dismissed. And so I think that moving forward, this is very much about hearing voices of women in our community, and not just those women who have the loudest voice either, the women who have the kind of the voice from our kind of poorest communities. And that will make sure that the vision that we create is very effective, I hope.
Any other members? Questions? Okay, I've got a couple of questions myself. I think touching on what you've just said there, Dr. J, about you know, sort of getting to the people not with the loudest voice and in the poorer communities. The PICS action to hand back the contract seems to have been the catalyst to review gynaecology services across the county, and it shows that Bassett Law didn't have the same as what other areas of Nottinghamshire did have. If PICS hadn't handed back the contract, would there have been the appetite to review and bring that equity of service delivery, or would Bassett Law again be the outlier and not get the services that the rest of Nottinghamshire receive?
No, we always had, so in line with the women's health strategy, we always had a planned review of women's health. It just so happened that this was a catalyst to then make that happen quicker, in effect. But we had always planned to ensure that we'd got equity of service across gynaecology for women in the community. But that was scheduled for early next year, so it's just brought that forward.
So I may take an inference from that then, that things have moved quicker because certain parts of Nottinghamshire were being or at risk of losing a service, rather than moving quicker to get a service brought to Bassett Law quicker. Could I take that inference?
I mean, so Bassett Law did have a service, it just wasn't in the community. So similar to other areas, some had community gynae and some didn't. So the service would be acute rather than community. And obviously what we want to do in line with the women's health strategy is to move care closer to home. So this would be part of the longer term solution. It was just the contract handback was a catalyst.
Yeah. Yeah, no, thank you for your you know, sort of direction on that answer. That's great. So for me, we talked as well about one of the key challenges of answering Councillor Wright was the backlog of cases to be dealt with. So could you just give us a bit of an indication as to what the timeline is to get on top of that waiting list? And in the meantime, are there any risks to women that are in that sort of backlog of cases, and how are we mitigating any risks that may present themselves?
Yes, so our timeline for completing is by the end of November, the RSS will have reviewed and booked in all of those patients. Modality is ongoing until the 31st of December. Our quality team in the ICB are monitoring the quality concerns. We've only had one complaint so far, and we did address the backlog in time order. So the women that had been waiting longest to be seen were the first to be booked into alternative provision. So we're now working almost backwards through that list, and we've got 2 more weeks to get through the backlog.
No, that's fantastic. Thank you. Any other members got any questions? Councillor Barlow.
Sorry, yeah. Is there any thoughts to further down the line that you might sort of like I mean, I remember years ago, there was a hospital in Nottingham that wasn't purely a women's hospital. Is there anything in the plans to perhaps have a women's centre?
So part of the kind of women's strategy was an initial focus on women's health hubs. And so that's something that we've been thinking of. But one of the worries I had about that was that what we wanted to do was to make sure that women's health was embedded in every bit of the system. Because unfortunately, what happens if you're not careful, if you focus on the women's bits, which are important, but that doesn't actually contribute to all health of women. So what we need to make sure is that women are considered in every bit. And so yesterday I was on a call with the university about cardiovascular disease in women because it's underrepresented in the kind of diagnosis we make. So we're very much thinking about how we make sure that all of women's agenda is included across the health system.
Guy?
Thank you, Chair. Thanks for taking Gemma. Can you just say a bit about the investment into the service? So we've gone from one contract. Is the same amount of investment going into the new service? And there's no intentions to change that?
Yes, so at the moment the investment is about equal between the activity that we stepped up to recover the position and the handback of the contract. So what we're now doing is then planning the longer term and that we want to sustain this capacity in primary care. And then the challenge for us is what else can we do to support our acute and care closer to home in line with the women's health strategy. So at the moment it's about the same.
Thank you. Just one last question from myself, and it relates more to the contract element of it. Obviously, the ICB had a contract with PICS, and that's being handed back. So is the ICB taking any learnings from this, and how are you looking to more proactively manage other contracts that you have, off the back of this situation?
Yeah, absolutely. So we've done a full lessons learned review internally within the ICB with various colleagues, including finance, contracting, quality, commissioning, etc. So we have looked back over the entire lifetime of the contract. As Nick said, that does include COVID. So what we're doing is then planning forward with those lessons learned as to what we do differently next time.
Do any members have any other questions? No? Okay. Well, I think that's been very informative, both the review and the presentation that you gave at the start, but then obviously the things that have come out from the question as well. And it does sound like you're on top of sort of the issues that were presented from PICS handing back this contract, and it's reassuring to hear that in quite a quick time the backlog of cases is going to be dealt with. So yes, very reassuring. So I thank you for sort of what you've given us this morning. So I'll just move on now to the recommendations, and the recommendations are that the report be noted. All those in favour of noting the report? Yeah, thank you. And that the feedback of members on the provision of community gynaecology services be noted. Thank you. We are a little bit ahead. We were expecting to do that item and then adjourn. So I think what I'll do is I'll move on to item 5, and then where we can find a natural pause in that. Maybe after the presentation, before questions, then we may adjourn at that point if everybody's happy. So the next item for consideration is a report from the ICB in respect of the existing support for endometriosis that is available in Nottinghamshire. Again, can I invite Gemma and Dr. J to introduce the report, please?
So I'm going to start this time, and then Jen's going to back me up first as she can. So endometriosis is a condition where the cells from the womb appear outside the womb. And so that usually is in the pelvis, but can sometimes be in organs around the body. So the cells that line the womb during the menstrual cycle, with the hormonal impact, will kind of break down, cause pain, and you lose blood. So what that means is that many women who have endometriosis will have pain from different organs, from the uterus, from the ovaries, but also potentially from kind of the bladder and from the kind of the bottom area as well. So the main symptom of endometriosis in most women is kind of pain, and quite significant pain for some women. It can also complicate life in terms of you have pain at other moments in time, so not just general pain, but actually pain during sex or pain that kind of when you go to the toilet. It also means that women are much less likely to be fertile. So it has quite a significant impact on women's lives. I think that what we can say from our kind of review in Nottingham is that the pathways that we have in place are ones that we need to improve on. I think the pathways and the referral pathways are something that we've been looking at, but actually getting them to be translated across primary care, secondary care and tertiary care is something that very much we need to have embedded. Nice recommendations, the nicer updated this year, is that you have a critical network. It's one of the things that we've been actively working on in the last few months, is developing that network of people who can embed conditions such as endometriosis better across the system for us. I think that all the areas that we've spoke of, and so we have secondary care services in Nottingham at NUH. If we need to have a more specialty opinion, then the patient will be referred to Derby or Derby Royal Infirmary, or they'd be referred further afield to Leicester or sometimes to Sheffield. And that's for the patients where they have a much more complicated disease called deep embedded endometriosis. So that's where they would need to have other surgeons involved, so not just gynecologists, where potentially to have colorectal surgeons involved, or they need to have a urologist involved for the impact on the kind of the other areas of the kind of in the kind of the pelvis as such. Also fertility specialists, so we do have fertility services in Nottinghamshire, but actually also we use other fertility services around our the East Midlands as well if we need to. You'll see in the paper that the numbers of patients that we have on our databases for endometriosis would be less than what would be recognised as a the kind of the from the United Kingdom data. And so part of that will be, there'll be women who aren't referred appropriately, there'll be women who have primary care. There'll also be part of the referral pathways, part because what we just spoke about, which is that women's voices aren't often heard, and it's how we make sure that all communities have access to services that we need. I think the other thing with endometriosis is an impact, quite a significant impact on mental health. So you need to make sure that you have kind of psychology services involved as well in the delivery of any service that you need. Just go down, make sure I'm not missing anything. So I think with endometriosis, it's very much a condition that's under-recognised. It's a condition that we need to have pre-referral guidelines for, to make sure that in primary care, GPs are looking after them and do so effectively. They need to know when to refer into secondary care, and they need to know when to refer onto tertiary care. And that very much needs that clinical network to be delivered. The two things that we've done recently, which will improve the situation, apart from what I've said about kind of pre-referral guidelines, are that there was a nice technology appraisal that came out earlier on this year. So the treatment for endometriosis is either hormonal, and you can do that using things like the contraceptive pill or the coil, but you can also do it with some other medicines. And so far, those medicines have all been delivered by injection, which has meant that those women have needed to go to the hospital to have those injections given. But the technology appraisal that came out this year is an oral medication. There's two different types of oral medication that could be prescribed instead. And what we've been working on over the last couple of months is making sure those medicines can be delivered in primary care. So rather than they can be initiated in secondary care, but what we want is a shared care agreement across primary and secondary care, and those medicines then can be prescribed in primary care, and that's what we've just got agreement to do. So the next few months we'll be working with proposals, so more women will have access to those medications, and they'll have access to those medications closer to home as well. So that's one improvement that will happen in the next couple of months. The other improvement is very much what we spoke about in terms of the Women's Health Strategy, the Women's Health Alliance. So we're very much involved with the gynaecologists at our kind of hospitals, both at Sherwood Forest and at Nottingham University Hospitals, and at Doncaster as well. So Bassett Law's part of Doncaster and Bassett Law Trust. And so we're working with all those three hospitals to make sure that they're all included in any kind of referral guidance that we need. So the Women's Health Alliance that we're developing will very much have an oversight and assurance group, and they'll have a much wider alliance of all those people interested in women's health issues, so that we can make sure that we have task and finish groups for these particular areas that we think need to focus on, and endometriosis is one of those areas that we do need to have a focus on. I'm just taking questions.
Thank you. Is that, you're not adding anything yet? Okay, I'll hand it over to members. Councillor Gowland.
Thank you. Obviously, this is an area that gets under reported, and health and equality matches into this. So do you know if there's differences, do you have data on differences in rates of referral or reporting across the county? Because obviously it's massive health and equality across the county, so I can tell you. And also, can I ask about women with educational, special educational needs, and whether those women are being reached at the service?
So I think, I mean, I've worked in health and equality for quite a long time, both in South Yorkshire and in Nottinghamshire, and I think, it's really obvious that for anything you look at, there are significant referral issues. Referral issues, access to treatment, it won't be different. And one of the things that we need to stop doing is looking for more evidence of it and just start doing something different. And so I think that we have some really good data on other women's health stuff that tells us that women are much less likely to be referred into secondary care if you come from a demographic which is much less equal. And that's because of patient voice. And so it's that ability to actually speak up for yourself. I think we have some really good data as well that tells us that for procedures that women are of most need have less, not access, but uptake of procedures. And that's something we need to have a little bit more of, whether or not the way that we communicate the potential offer is the right communication. And that's something that we need to think about in terms of our secondary care providers. And I include any different specialty with that. There is something around the kind of cultural requirements that we need. We have a large mix of ethnicities and cultures across our system. And we need to very much take that into consideration when we're thinking about the offer that we make and how we communicate. In terms of special educational needs, and that is a wide group of people that we need to include. And we have some, we don't do it well enough, to be honest, for anything. I mean, it's kind of, we have, you have accessibility, and so you have an offer made by both primary care and secondary care in making sure that if you identify somebody who's got a special educational need, then you actually offer appointments differently, and you make sure you communicate differently. And that's all there. But whether we recognise everybody who has a special educational need is a different question. I think sometimes that's where we fall down, is that we put these things in place to make sure that it is recognised the need and something different is offered, but we don't recognise it in the first place, and that's more difficult to actually have that. And if we think about the kind of gender gender, often it's in the kind of non-white population where this gender gender is less well spoken about. And so sometimes I worry that that compound of the different problems across our system as well.
I mean, I completely get what you're saying, that's not sure let's do, but can you just give a tangible example of something that's being done to try and address this in say North?
In North Nottinghamshire,
well, I mean, somewhere across Nottinghamshire to try and change the service and make it.
Yeah, absolutely. There are so many really good examples of kind of where we're addressing. So one that springs to mind that was hugely successful was the targeted health lung checks. So that was delivered last year, and what that did was very much focused on the population who were most unequal. And it had a dramatic improvement in the lung cancer diagnosis rates for that population and lung cancer survival for that population. And so what we're using is every bit of evidence we have of how to make sure the services that we offer are given in the right place. You're constantly, the problem you have, and this is a real problem that we need to tackle together, is that the people who have the most have the greatest voice, and they constantly want to pull. So you're trying to stop the pull at the same time as delivering more in those communities that most need it. So it's about all of us, I think, both in terms of the council, making sure that when we're talking to our constituents and we're kind of speaking about how we're trying to narrow the kind of the gap between health and well-being, is that we have to concentrate more on some of those who are most unequal. Otherwise, we won't change the pitch that we currently have.
Councillor Rich.
Right, so I'm going to go straightforward talking here. So when I go to my local GP, I walk into my local hospital GP, there's loads of posters about LGBT, posters about diabetes, all that stuff. What I've noticed, something like endometriosis, is there any reason why we don't see anything like endometriosis or anything that's to do with women's issues? It's something to start advocating for. Because at the moment, women don't know what conditions they have, they don't know if they have an issue, they want to know who to speak to, how to get the right support they need. Basically, I'm advocating for women at this point, and they need to know where they can get the support. And that's what they need. They need all the information in front of them so they can actually know and take that information on board. Well, what's the NHS think on that?
So part of the women's health work that we want to do within the Alliance is very much 50% of it is communication and dissemination. So you can put as much as you want to in place, but unless people know about it, the offer won't be taken up. So that understanding of women's health issues is really important. I mean, we have some fantastic websites already available in terms of women's health. There's a fantastic website on endometriosis. We have a women's health group across Nottinghamshire as well. And also we have for the city, we have Ask Lion, and then we have some very similar communications from the county as well. And in the future, there's a plan to join those things up so we have kind of one kind of resource available. In a GP practice, then they will display things that they're pertinent for their population. And there are things, in my own GP practice, and I see lots of stuff around contraception, I see lots of things about menopause for women. Endometriosis has probably been one of those orphan areas, and so it's something that hasn't been as well recognised in the past as what it needs to be. And that's why, when you look at our figures, we have the numbers that we see in GP practices coding is less than we'd expect for our population on the national kind of agenda. And that's something we need to correct. We were in the same position with asthma a decade ago. We looked at GPs databases and asthma wasn't recognised. We've managed to improve that situation. So you take your learning and you actually need to make sure, first of all, that women recognise the problem. And that's very good. And what we need is men to speak up for women too. So if, most people are in partnerships, whatever type of partnership it is, and so you need to make sure that kind of people speak up for each other in terms of women who pain.
Just a follow-up on the second question, if I don't mind.
Yeah, absolutely.
So if that's the case, do you think women to feel being pressurised because it's like 7.5 years for a diagnosis of endometriosis? Do you think women feel like I've given up because I'm not getting the support I need, so why should I bother going to my local GP or go to my local hospital to get the help I need?
I think women often deny their own symptoms or how bad they are. I think they tend to advocate for other people, and that's probably being a woman more than anything else. I think what we need to make sure, and I think increasingly so, is women don't stop speaking up when they need some help and support with something. I think that it does become destroying if you go to a healthcare provider and they tell you that your symptoms are not real symptoms or they don't recognise them as being significant enough. And we know particularly for our communities that come from different cultural backgrounds, that pain is something that's less well recognised in different communities as well. And so I think you're right in that totally what we should be doing is making sure that when we do all the communication around the women's health work, we're not just including women in that, we're also including all our healthcare professionals to make sure they recognise the conditions that affect women. And so that when you do go and see your GP, your symptoms aren't dismissed. And often, if I'm honest, then having a good number of female GPs involved in those pathways is sometimes important, because women might find it easier to talk to another woman about something than they might be able to talk to a man, but it's about having that available as well, and that's something we do very well across Nottinghamshire.
I've got Councillor Barlow and Councillor Adegoke on my list for questions, but I've just noticed we're closing in on 10:45. So I'm going to call an adjournment at this point so that we can go and observe the 2-minute silence for the armistice, and then we'll come back and reconvene and have further questions. Thank you. Okay, thank you everybody for the adjournment. Obviously, observe the 2-minute silence. We are now back live broadcasting. So we'll continue obviously with the questions with regards to the item on endometriosis. So I'm going to come to Councillor Barlow, who's got some questions.
Thank you. Yeah, so I know that obviously it says that it affects 1 in 10 women, and that obviously there is 4,285 women in Nottinghamshire have been diagnosed. But it's not currently feasible to access more detailed data from individual GP records to explore the gap between this number and the estimated 30,000 people in Nottingham. If you can't access that data, how are you going to try and recognise these missing women, if you like?
So the important thing is what we were discussing before, which is around both women and healthcare professionals recognising endometriosis and symptoms that cause it and diagnose it and coding it. So I think that's part of the Women's Health Alliance approach, is to focus on that kind of the what do we need to do, the information that's required, and then how do you communicate, disseminate that to make sure that it all matches up. Because many of those women, if it's been diagnosed, it will have been identified. So most of it won't have been diagnosed. So some of that will be in primary care in terms of the kind of the women that aren't recognised with pain as having endometriosis. Some of it will be people who aren't accessing primary care because of either they don't understand the condition or the disease, or they don't know how to access primary care, or they don't understand the pathways for diagnosis of endometriosis. So there's lots of work to do on that area, and that's how we will build up the kind of diagnostic coding and make sure that we recognise those women who do have it.
Can I just ask in that case, and obviously your first point of call is referral to is to get to your GP. We've already mentioned getting a GP appointment is hard work, and like Councillor Rich said earlier, there is no posters or anything like that. Is there no plans to have like a designated campaign for this, just to make women aware that this could be what their problem is?
So there was I think what we need to do is understand what is required for each individual condition. So from the Women's Health Alliance, we'll have a number of task and finish groups, of which one of them will be endometriosis, one of them will be menopause. There are 2 that we already know that we need to do. There's lots of kind of excitement around group sessions as well for women. So women are often quite collaborative. And so I think what we need to understand is what's the healthcare approach that's required to make sure that they have the information that they need. If part of that, it's recognised that we need to have some kind of communication and strategy, then of course that will happen. You know, we have a really good communication team in the ICB, and we have some of our own health resources on the website. I don't think that would be the right approach. I think it's how we make sure that we reach those women who have symptoms of this. And to do that, we need to understand where they are in our communities, to understand who are the best people to communicate that details to them. And we concentrate quite a lot on GP practices, but GP practices aren't always the right place sometimes. If we think about our community, there's often trusted leaders in other parts of our communities, where sometimes that messaging comes better from them and not necessarily from GP practices.
Thank you. I know you sort of mentioned menopause there. Now, there's been a lot of publicity around menopause. It's on every television programme you watch. There is nothing about endometriosis. And that was the point I was trying to get to, that there needs to be a similar sort of campaign to get it across to women that may be what they're suffering from.
Yeah, I don't disagree with you. I think the endometriosis, like I said earlier, has been kind of quite an orphan disease because it hasn't been recognised. Because it presents with pain, women have menstrual pain. Is that menstrual pain or is that endometriosis? And so it hasn't been recognised as a diagnostic condition for many women. So I think the first approach is to understand what communication needs there are, and then design a campaign around that, design what needs to happen. And that's not me saying that we're going to do that. That's how, what is it women need to actually empower them to have that voice.
Thank you. So, sorry to sort of go on about this, but with the menopause, you know, they've publicised, you know, hot sweats, various other things. Why aren't we actually publicising some of the other symptoms? So it's not just period pain. It is because you might have this as well or this as well. So that's the point I'm getting at. You're not actually answering the question so much as you say you want to diagnose it, but if you advertise it so that women know that it's more than just period pain and that maybe they need to go to the GP. That's why I'm saying, do we need a more of a campaign like we had around menopause?
So I think the menopause campaign has been really successful at accessing women who have the most voice. If you look at our demographics and who accesses HRT, then you will see a skew towards those who are the most affluent. Who's doing the ICVs, not necessarily repeat campaigns that actually meet the requirements of one set of the population, not the other set of the population. I think it's really important that we understand what women's needs are and co-produce solutions. We have the Strategic Health Needs Assessment from City Council. We have the Director of Public Health report from last year from the County Council. And if you ask the question of the responses from women in both those and the service they did, they're from the women who have the most. They're not from the women who have the least. So of course we can do a really easy campaign. We can put it up there. We can put, you know, causes pain courses, but it will only reach the women who have the most, not those who have the least. So I'm not kind of trying to not answer your question. What I'm saying to you is that what we need to make sure that we do is reach all the women in Nottinghamshire, and that's not necessarily by putting up posters in GP practices, if I'm honest. I've done a lot of work on health inequalities, both across South Yorkshire and in Nottinghamshire. And what we're very quick to do is to spew out literature and just say, there, you've got it, we've done a campaign, but does it actually meet the requirements of the people that we need to get to? And I'd say not necessarily so.
Councillor Adagoki.
Yeah, I think some of my colleagues have touched on some of the things that I'm actually going to ask you about, Doctor. But from the way you've spoken so far, it appears to me there's an illusion of care on endometriosis, you know. And I don't think that's very good. This is a condition that's affecting more than 30,000 people in country, and it's got no cure. And tissue can be found in many parts of the body. It doesn't just stay in one part of the body. It just grows in different parts of the body. It gives a lot of pain, and people are suffering. Now, we've got a lot of women in the city who might possibly be able to get to the GP quickly and talk to the GP, or get a friend, or get a son or a daughter who's in the medical profession and things like that. But what about women of color? What about women who are in the villages, rural women, who go through this? And your diagnosis period, you know, the time within your the time someone comes to you and when you diagnose that, it's also very long. So there's a problem with what you're doing on endometriosis, and I think there's an illusion of care. It appears you're providing service, it appears you're looking after the women, you want them to have care, you want to support them, but actually not there. And that's the illusion behind what you're saying, because listen to you, and I listened to Ms. Barlow and Joseph saying the same thing. On TV, people talk about menopause, talk about this, or talk about that. It's everywhere. Well, how can we have a disease that's got no cure? Affecting 30,000 women, it can affect a lot more. 1 in 10 women has got endometriosis. And it's not being publicized. I mean, I find that not good. I really don't like it. And I think you need to get a grip on that. And I think you need to come out strong and begin to talk on this. And get people to know when to go, how to go, what to do, what the problem actually is. This is a tissue that grows, you know, similar to the uterus. So, you know, in the, you know, the lining of the uterus. And it just goes around the whole body of the women. Sort of. And so I think we need to get a grip on it. And I think there's an illusion of care there, which we must address.
So you're right that the endometriosis is a problem where cells go into different parts of the body, but that's infrequent. So for most women, it's just in the pelvis. For most women, it's localised around the uterus. So that's why gynaecology service is the most important element of this. I disagree that there's an illusion of care. There's nothing that I do that's an illusion of care. I'm a healthcare professional and I spend a lot of time providing patients. So I would disagree quite strongly about an illusion of care. I think that it's been an orphan specialty. I think there are many orphan specialties and many orphan specialties that affect those who are most vulnerable, particularly women and children. So I think what we need to do is have a focus on kind of conditions that affect women and children. I totally agree with you. I think I've spoken quite a lot today about health inequalities. I think the fact that we have a proportion of the city that is quite significantly not white means that we need to make sure we focus our attention on making sure those people have the correct diagnosis. And that's why when I was replying to Councillor Barlow, what I wasn't going to do is just say we'll have a tick box exercise. I could quite easily respond to her and say, yes, of course, Councillor Barlow, we can go and put posters up in every GP practice, but that won't reach the people that we need. And what we need to stop doing is repeating the mistakes we've made in the past. The only way forward is to stop repeating the mistakes we've made in the past related to this. We've got a health and faith alliance that's being developed. We've had a really successful campaign about Know Your Numbers, where we've used the Black Majority Church to actually support finding of people who've got hypertension. So we're going to use the same way and work with our other kind of leaders across the system as well to make sure that when we do make change happen, it meets those people's needs of those who have most unequal health. And that's equally the same for mid-knots as well. You know, the majority of the population in mid-knots is not a wealthy population. What we find is they don't access services in the way that they need to access them. So we need to make sure that we have those population needs that are met. Yeah, so I totally disagree. It's an illusion of care. There is a care there that is very profound, and from people across the ICB, that's what we do. That's what we do on a day-to-day basis. So I'm really sorry if you feel like that.
That's okay, thank you, Doctor. Well, I think a disagreement is part of the illusion of care. That's how I feel about it. Because if the care system is very strong, very robust, we would have been hearing about this a lot longer than today. A lot of people here, some of us here probably don't, it's there, but we don't think of it, as something women go through until Catherine brought it to all our attention that there's some of the things we've got to talk about, and I think that we should not deny what we're not doing wrong. We should just agree and get it done the way we should. I think the care is there, but it's not getting out to the people as it should. Okay? I think we need to publicize it a lot more. Just like Joseph, Councillor Rich said, we need to get it to people. Where are the leaflets? I've been to my GP, but I've never seen any leaflets on endometriosis. I've been to several GPs, I've been to several hospitals, and I've gone to several health care systems. I've got family members who are in, just like you, in the NHS as well, and these are not issues that we get to hear often. And I think we need to make a lot of noise about it so that women in the rural community can understand what this is and find a way to get care quickly when they need to. So that's just one of the things I would say. I appreciate what you're doing, and I'm not condemning what you're doing. I believe you're doing what you can, but I think we need to step it up a little bit more and get it out to the people a lot more. Talk about this. This is a disease that no cure, but we can help people get through it as best as we can. It's a very painful disease as well.
Oh, I know. Thank you.
Thank you.
I've got a few members that want to come in, but I'm just going to summarise, I think, a key theme around what Councillor Barlow, Councillor Rich and Councillor Adigoke have been sort of centering on. And it came out in the gynaecology item, and obviously it's come out in this one, where we're talking about those with the loudest voice, those that have got a degree of affluence, are the ones that get the information and can guide themselves towards access of the appropriate care. I don't think sort of poverty, social inequality and deprivation has happened in the last year or so. This is 30, 40 years, since the deindustrialisation of certain, parts of this county. So surely there should be lessons already there. You know, we've had this for decades now, and we still seem to be failing to hit the mark by getting those who are disadvantaged in terms of, you know, where they live or their, you know, their affluence. So is there anything the ICB can bring forward now from all the decades of lessons learned to better target, you know, the message about endometriosis and the care that can be offered?
So there's lots going on around social deprivation. As I said before, there's lots of successful projects that we've had that we're using to make sure that initiatives for other programmes are what we build from rather than starting fresh. I think for endometriosis, we need to understand from our communities how we need to address that. As I said at the start of this presentation, there is a gap there at the moment that needs to be filled. The Women's Health Alliance was already starting to be developed before this request came from the county about endometriosis, and so that was already ongoing. Those links were already being made with our professional groups. So I think it's about working together. If we try and do this really quickly, it won't be successful. So if we just say the response is to put posters in GP practices, that won't work. The learning from everything we do is that we need to improve diagnosis of conditions through trusted members in communities. And so sometimes that's GP practices, because they're trusted professionals in communities. Sometimes that's other parts of the system that are trusted members in communities. And so we can have, it would be really easy for us to put lots of data on Ask Lion, on our ICB website. You know, we could do it tomorrow. Would that reach the people that it needs to reach? Then I would suggest that it would actually have a particular box quite easily. And I'm sorry, that's not what I do as a healthcare professional. So I think what we need to do is we need to make sure that we reach the people that we need to by building on the communities that we already have, and that's how we will achieve success.
I think that was the premise of my question. It wasn't a medical question. It was, how are we getting that message out to the people who need that information? It's not a medical thing. It wasn't focused on endometriosis. It was focused on how we are 30, 40 years down the line of poverty and social deprivation in certain parts of this country. And a lot of that comes from the fact that mining communities have been decimated, and they used to have community healthcare and things. So we're decades down the line. So the question is, when we're decades down the line and we understand that those at the bottom end of the scale aren't getting the information and aren't getting the care, why are we decades down the line and we still haven't learned the lesson and got the methodology to engage these people and get them into care? So it's not a medical question I'm asking. It's very much, you know, why are we so far down this line and we are still just going around and saying we need to learn lessons? Social deprivation's there. You know, we should understand it and we should be able to guide and focus services, and we don't seem to be able to do that. So that's really the premise of the question.
So I don't disagree with you. I think we don't need to learn any more lessons. We just need to do the action, and that's what I said quite clearly, is that we need to do things differently, and that's the whole premise of the NHS 10-year plan, which is moving services from hospitals into community. So you remove that resource from hospitals into community as well to make sure that you get that left shift, so people have access to care closer to home. That's the whole premise of what we're trying to achieve. I think the pandemic was the kind of stark recognition of health inequality as well, in terms of that recognition of things needed to change, even though many of us knew before that reality existed. Sorry, Jen, just
I was just going to say, if we go back to the previous paper, I think about gynae. So we now have access to gynae services in an additional 29 locations. And I think in the previous conversation, we said actually rather than having one specialist centre, whether it be a women's health hub or an acute hospital, actually what we need to do is disperse that model and make sure, in line with the 10-year plan, that there is more access to services closer to communities. So that's a good example, albeit due to a contract handback, but around how we are making services more equitable and access to them by pushing them out into communities rather than a single centre, and that will absolutely help.
I may come back to some of that, you know, in my summing up, but I have got other members. So, Councillor Garland.
Thank you. I realise I get that this is your thing, right? You do health and equality, it's your life, and so don't, you know, I know we're being critical, but and it's hard. So I asked for examples. You gave me one from lung, and then you gave one later on hypertension, and you've talked about building trust and co-creation and all these words that we understand. But I think what probably would help is what is the timescale, or what are the tangible things that are being done in this area in the next 6 months to actually reach these women? Because I understand the goal and I understand the methods, but I think it's what's happening now, and I appreciate it's, you know, it's an ongoing action.
So we have our first meeting in December of the group that will be kind of the assurance and delivery model for the Women's Health Alliance. So that will include public health from county, public health from city, building on the strategic needs assessment that's been done, and building on the Director of Public Health report for women from last year from County Council. So it'll include the providers, and from that meeting there will be a prioritisation. So it will be, what is it that we need to prioritise our attention on for women in the next kind of 6 months or so. From that, there will be a number of tasks and finish groups that will start in the new year, where we then understand what it is, where the gaps are for particular conditions, and how do we reach out to those people who don't have access. So the hope would be in 6 months' time, we'll be in a much better position than what we are now, but I think that's the important step. I think it's not just about kind of putting up posts in GP practices, about understanding from our system partners what it is that everybody's seeing that needs to be prioritised. And that's where you come back to some of these conditions in terms of prioritisation. Some of it's around community voice and raising the voice. Some of it's what public health find a need for. Some of it's from the healthcare professionals themselves in terms of the identification of that disease and the severity of the disease and the impact on people, either in terms of the morbidity or in terms of the mortality. And all those things need to take into consideration when you're producing programmes at work. So for the Women's Health Alliance, that is the plan. The first meeting's in the diary for December, for the task and finish groups from early next year, that includes all the people that I've spoken about already, and primary care, and the voluntary sector, and the women's kind of centres that we have in Nottinghamshire. They'll all be part of that.
Councillor Wright.
Yeah, thank you. It amazes me that you say that posters don't work. When I walk into a GP, there's more posters in a teenager's bedroom everywhere. And I just think we need to get that message out there.
Yeah.
I think there's a, let me finish please. I think there's a message coming from everybody. I want to get the subject on the table. If it wasn't for the fact that I'm a member of staff in a company I run, suffering from this condition, I wouldn't know it existed. And we need to get back to basics. I think seeing it on a poster will do that. I'm sorry, I think you're totally wrong, and find that a little bit patronising to say, well, that's there. Some people need a poster, need a visual image of it. So the question is going to come. If this was a male problem, it would probably been sorted out years ago, to be fair. And I think you ladies have got enough issues health-wise with menopause and complications. What is being put in to educate male GPs with this? Because I think there's a problem. I have information that is a problem.
So in response to your posters, what I was responding to was Councillor Adeoki's about the women who have greater need in different communities. So posters don't necessarily work for reaching all those with health inequalities. And so that's what I was responding to, not they don't work for other people in our communities. So in terms of your second question, sorry, just repeat it again.
What are we doing to educate male GPs? Because again, I mean, my wife will go regarding menopause, come away upset that over HRT that he doesn't understand. It angers me as a husband, to be fair. I don't think there's any empathy there. And now we've got this other issue coming along. Is this going to be repeated in joining with the rest of that?
So it's been recognised that there isn't enough knowledge in primary care around some of the women's health needs, both in terms of not just male GPs, but female GPs as well. So I think it's across the board. So when I was suggesting earlier that the kind of the work that we're doing with the Women's Alliance, half of it is about producing those services and strategy, but half of it is around the communication and how we do that and what education we need to enable that to happen. So I totally agree with you, education is really important, but actually it has to be the right education to the right people as well. And who is it women want to see? Who do women go to if they want to have a conversation about something related to their general health or the health related to gynecological problems? It might not be the male GP they choose to go to. So I think we need to work with that as well. All GPs need to know, I'm not saying that, but actually what I'm saying is that we need to make sure that women have the access they need to the people that they need.
Just go with the posters, yeah.
Thank you.
Councillor Rich.
Hi. Right, so I'm looking at this about the data of the 30,000 women probably affected in Nottingham and stuff. And they all seem to be going to Derby, let's be honest. They're not going to anywhere in Nottingham. There's nothing, let's be honest, there's no support of endometriosis in Nottingham or Nottinghamshire, let's be honest, let's clear that. So they all go to Derby, right, to go and get their diagnosis, whatever they need to get that support. What is your plan now to solve this issue? Thank you.
Just let me know what you think, where's the data on, they're all going to Derby.
So with the diagnosis they have to go away from, there's no such thing as a diagnosis in Nottingham and Nottinghamshire, and there clearly isn't, because looking at the data, this, the details from all different sources of the website, not just this anyway. And usually they get referred to by some sort of local GP, possibly if they might or may not know, but the majority of the time they get fobbed off, most women do. Right? They'll say, oh, we've got bowel issues, we've got this, we've got that, and they've been fobbed off for so many years. This is why there's a number of like 7.5 years where women are struggling to get to diagnosis themselves. But when they do get been referred to, sometimes they're more likely pushed down to where to go to Derby itself to get the diagnosis.
So they don't get to Derby to get a diagnosis. So the pathway what currently exists is that you would have symptoms, you go to your GP would recognise it as a problem. They would refer into secondary care, which for our patients in Nottinghamshire would be either Sherwood Forest, or it would be Nottingham University Hospitals, or it would be Doncaster and Bassett Law for those further north of the patch. They'd be seen by gynaecologists in any of those three services. You can offer that first tier of treatment for endometriosis. So they might, in those secondary care providers, what they would do would be, they might do some ultrasound scans, they would do potential laparoscopy to understand where that disease is. They would give them some treatment, either contraception, or they would give them one of the new medicines that I spoke about in terms of an injection. They can also have local resections as well. So if they find bits of tissue that they feel they can take out, they would do that in that local provider. What we don't have in Nottinghamshire is the tertiary level of service. So the level of service is what is called one of the VSGE endometriosis centres. So they are NHS England commissioned specialist services, which are only in certain places. So that's why when you look at those figures, there's only a small number of patients that goes to Derbyshire. I'm not saying that we shouldn't have those in Nottinghamshire. What I'm saying, the current pathway is that if we have more patients that are diagnosed, we'll probably find more women that have the deep-seated type of endometriosis, which may mean then we have enough of those cases to be able to deliver those services in Nottinghamshire. But that's a totally different kind of discussion than what we're having today. So that's the kind of the final element of the pathway in terms of that deep-seated endometriosis.
Councillor Cox.
Excuse me, thank you. Can I just refer to page 26? It's relevant on the question I'm going to ask. 1, 2, 3, 4, 20 paragraph down between October and December 2000.
Sorry, which page again, sorry?
26 of the report.
Oh, sorry, in your pack, sorry.
Yeah. Well, I'll read it to you anyway. It's a fairly straightforward thing. Between October and December 2024, Nottinghamshire County Council ran a women's health survey. Now, I've just gone to the health survey, and it actually links into what council wanted to talk about marketing and advertising and get this information out there. And one of the questions on that report or survey was, and it's question 9. Where are you most likely to get information about your health and well-being? And there's a whole host of options. Thank you. Interestingly, in 2025, it doesn't surprise me that social media is right there at the top as being a place where people go. And I know from personal experience with my wife, when she was suffering through the menopause, she resorted to Facebook and Facebook groups and stuff like that. So in a long-winded and long-rounded way is, have we considered the social media aspect and stuff like, and setting up, because interestingly, the worst performing response was the NHS 111 line. Now, to me, we are 2025, going into 2026, we've got all this modern technology. Ought we not be looking at this and saying, okay, let's utilise the tools we have to our hands now and use it as best we can? Because to me, that says everything about how we need to get and how we can get the word out there. And so I suppose the long-winded question is are we and have we considered using social media as a platform?
Absolutely, and I totally agree with you. I think that social media is the way to go, and we know that from many different people, that's where they get the majority of the information. I think we've had I've been involved in some very successful campaigns in the past where we've reached out to people, managed to get them to access the information they need, particularly for those who have most unequal health as well. It's the way that they recognise their health resources. What they also need is to make sure that on those social media devices that the health information comes from the local people. So, you know, how I would do this, what I need to do is make sure that it's something that's supported by the women and by our other healthcare professionals, is I would have gynaecologists for each individual GPs from our individual places, putting messages on social media about endometriosis, about other elements of women's health, because they are the trusted people where the information is coming from, and that's how we know they recognise it as something that's important. And so, you know, there's some really good campaigns where, again, thinking about immunisations, if the information comes from central government, it's not always recognised as something that's important. But if we have our own healthcare professionals in our system doing things on social media, that may well represent a really good campaign of how we get the information out there.
Thank you. And I want to close on this one, please. Yeah. And I accept that, you know, to get the information from your local GP, a person you may know and trust, absolutely. But you find that these groups are made up of people who are actually suffering from these issues and give you far much better advice and guidance as to how to deal with it and what to do than having a GP who may well be snowed under with his own workload to be taking the time. When is the GP going to get the time to sit there on Facebook or on Twitch or TikTok or whatever and make a comment about, well, if you're suffering from this and this? I think, yes, there should be a pathway to, you know, from the Facebook, TikTok, whatever. But I think that the aspect or the idea that we're going to get a GP or medical professional to sit on TikTok and Facebook is not a realistic ask. So I think we should utilise the modern technology, but not expect a GP to take his time or a medical professional to take the time and sit there and sit on Facebook. I thank you for your response. Thank you.
Thank you. So there's a Nottinghamshire Endometriosis Society, which is made up of women who have endometriosis. So they'll be very much part of included in the group. And if they wish to do that, that absolutely would be the offer. So I agree with you that, you know, using people who have lived experience with the condition is often a really positive way of engaging with the rest of the population too.
I'm going to come to Councillor Barlow next, but I've also got Councillor Wheeler and Guy who also want to contribute to this. So I'll probably wrap up after that, because we do have other agenda items as well, unless somebody's got something burning that they wish to bring forward from that. So just for your awareness, I'll hand over to Councillor Barlow.
Thank you. Just a couple of sort of quick questions, really. One, obviously, it says on here the average waiting time for first outpatient appointment is 14 weeks, for example, for UH, and then 17 weeks is the average waiting time for treatment. Is the 17 weeks on top of the 14 weeks, or is the 14 weeks included in the 17 weeks?
So I think often when you're on a new pathway, the clock can start again, and that's something that we need to work with our providers on. It depends upon what it is that's being requested, and so sometimes it will be from the initial referral, but sometimes it will be from you stop the clock when someone hasn't had their first outpatient appointment. So sometimes it can be a new pathway that they go on to.
Thank you. Following on from that, is there any evidence to say that this is becoming a more common problem, or is it just that we know more about it, so we're diagnosing it more? But if it is becoming more common, is there any research into why it's happening and looking at maybe preventative measures?
So it's not my area of expertise, and so I can't really answer that. What I do know is that it tends to run in families, and so the genetics of these conditions. If you think about non-communicable disease in general, of which this is one of them, all of them are becoming more prevalent. And there is a lot of effort to try and understand why that is the case. So it would fit in with any kind of condition, so that is non-communicable disease. It won't be genetic changes, and genetic changes is the reason why you see a massive increase in prevalence sometimes. So it's kind of understanding why, in general in health, we have an increase in non-communicable diseases. In terms of research into endometriosis, there's a lot of research going on in the UK, but I can't quote that to you because I'm not a gynaecologist, I'm afraid.
Councillor Wheeler.
Yeah, thank you, Chairman. I think first of all, Councillor Richards points to item 3 on the appendix items, we can just detail the pathway there is not communication, what to share that with residents, and it was mentioned by the doctor as well earlier on. But I think what's communicated when it's collated, it's clear that when people are getting treatment, that's great. No, so they're getting into that there, they're getting a good level of treatment. It's about a communications plan that we, mentioned counsellors and council and other partners can do to help showcase the need to stop them the symptoms and the fact that there is the need to that barrier between that. So what I think we're really good at come back to the community or be presented differently. Communication plan and practice and graphics and images that council can share on social media. I mean, lecture council will be on a social media platform on community groups locally, get a huge reach. So Nottingham County Council Facebook team social meeting, so we can have important channels, speaking from the borough council point of view, where it's not really on, but you're happy to share that as well. So there is that out there to do. I think that'd be really useful to see. We've always seen when people are given some great personal examples of when family members have seen those, this case there. And I can just think of, listening on the radio and TV about the prostate campaign that that made, going to, talk post, going to the toilet in Nottingham Forest, you've got the post up there about in those sort of areas where perhaps that sort of demographic goes again, perhaps more likely to not go to the doctor as much. So in fact, we share that because end day we can help to get that, because I think as Alex will no doubt said, when you've got comms say people are engaged, we look at your comms already, and perhaps the ones already going to doctors, like trying to reach those people who aren't, so we can do that by helping out that way. Thank you.
That's very kind of you, thank you.
And Guy.
Thank you, Chair. Similar to Councillor Wheeler, just sort of two halves for this for me. One is around raising awareness, and we certainly talked about today in this discussion. And then it's about the confidence in the level of service people will get at the end of once they've been made aware. I think there's something for, I know I've just looked, there's only just videos on which gives raises awareness. So there's tools there that we could use already. I think we also have a joint strategy around carers. I think lots of carers are women, and I think we could do some work together on there. I also think we forget about our own workforce. Our own workforce are many of whom are women, but many of whom are working in communities and are working with people who are maybe in poverty or have less of a voice. I think we could think about how we can do some awareness, some awareness with our workforce to enable them to have those conversations. So we can just open this up a bit more. So I think we can work together on that sort of thing.
Yeah, no, I totally agree. Thank you. Very good.
Okay, thank you. So I've not paid them to do this, but I think Councillor Wheeler and Guy summed up the discussion quite well there, so it saves me a lot of a job. And I think just amplifying what Guy has alluded to there are some, from my point of view, two strands to this that we've discussed today. There's the care element, which clearly, needs a lot of work. When women are spending months and years to, sort of get treatment or even a diagnosis. So I'm sure there's work to be done there. And then there's the bit around communication, and that isn't just on the shoulders of the ICB either. As a local authority, we've got a part to play in that. And I very much, as the chair of this committee, would like to engage with you to see what we can do in this space, especially around this condition, which fundamentally affects women and their lives. Yes, that's definitely something we'll look into. So I think I'll wrap it up at that point. But what I would like to say is we've talked across two items there that are very much focused in, sort of women's healthcare, and it's something that we wanted to bring forward and champion as well. And it was interesting hearing about the women's health strategy. So I would at some point, not in the near future, but when the wheels are in motion a bit more, like to invite you back to probably give us an overview of how the women's health strategy is progressing. We shall arrange that at some point. So I thank you for that. I'll now move on to the recommendations. And the first recommendation is that the report be noted. I'll accept your report noted, thank you. And the second recommendation, that feedback of members on the support available for endometriosis be noted. All agree? Yeah, lovely. So thank you very much for all your contribution there. I'll move on now to item 6. So item 6 is social prescribing. It's one I'm really interested in. So the next item for consideration is a report from the ICB in respect of social prescribing across Nottinghamshire. Can I invite Fiona, the ICB Place Partnership Director, to introduce your report?
Thank you and good morning. Yes, just good morning, everyone. I've got some slides just to highlight some of the points, particularly that you picked up after the report was produced. But I'm really pleased to be able to talk to you about the social prescribing work that's taking place across our county. Many of you recognise that much of health and wellbeing sits outside of the NHS, and that we need to work across our partnerships and our network to really improve people's health and wellbeing. And social prescribing services really provide that connection between the NHS and local services, local communities and local organisations, and particularly signposting and directing people to other avenues of support and opportunities. And we've seen lots of evidence nationally about how social prescribing can support particularly social isolation, mental health and wellbeing, and areas of helping people connect more to their local communities and those communities that offer those kinds of support. So the social prescribing link worker, sorry, next slide. The social prescribing link worker works with a range of professionals, and I'm sure that you've come across them in your communities, working across a range of both clinical, non-clinical and community services to really connect people to local communities. And we're really fortunate that we have a range of services taking place across the county. Next slide, please. I really wanted to talk to you about the way it's provided across the county, because I know that was some of your questions. So from an NHS perspective, it's social prescribing contributes to our delivery of personalised care, particularly the focus that we have around all our services and trying to encourage much more personalised care, as we've discussed earlier, agenda items. But the actual contract for social prescribing that's provided via our general practitioners is through a direct enhanced service through the primary care network. So it isn't something the ICB commissions, but it's nationally commissioned. And Across our 24 primary care networks, that's 15 in the county, all of them provide services for social prescribing in various different mechanisms. As part of the contract, there's a requirement for primary care networks to provide a social prescribing service to all their patients. And if you've looked at any of the links in the paper, you'll recognise there's a lot of various provision across the county. But there is no requirement for us to obtain information about those services. The requirement is for that to be provided, and local providers monitor how that's being delivered as part of the additional roles that primary care networks provide. Next slide, please. So I did want to touch on some data, and this is the social prescribing service in Rushcliffe, which is provided through Partners Health. And you can see from some of the data that's going back to 23-24, the level of social prescribing that's happened over the last 2 years, but also you can see that that's already starting to see an increase in Q1 particularly. You can also see the types of requests and advice that social prescribers link to patients in their communities. And you can see by far the most one from the Rushcliffe perspective is around mental health and well-being, but social isolation and advice on cost of living is also significantly a proportion of how people access those services. I also wanted to give a flavour of the types of appointments, because you talked about in the paper around waiting times. And one of the things that providers do is look at different ways of providing those services. And you can see a lot is done over the telephone, some is done face-to-face, but a lot is also starting to be done through group consultations in group settings where people have areas where they might have similarities. If you've been in the West Bridgeford Community Hub next to the library, you will see on a Monday morning that there is a social prescribing hub. And that's a way in which people can access local services. And that's a real, I guess, starting point for a much greater neighbourhood hub example that we might see going forwards. Next slide, please. I just wanted to touch on the ways in which social prescribing really reach out in other areas. And we've got a really innovative pilot. It's only happening in Rosewood PCN at the moment in Mansfield, but they're working with the Connect to Work opportunities and working with a range of providers. Futures is a Nottinghamshire-based provider in terms of getting people back into employment and training and education, and really trying to use the social prescribing link workers to identify people who might enter into that pathway. And we're starting to see some really good outcomes in terms of the reasons why people aren't in employment, what perhaps support they will need. Now, this is really small, but it gives the opportunities and where we can go further, particularly using the kind of NHS and education and work areas going forward. And there's lots of good feedback coming from that service. Next slide, please. And then finally, I just wanted to touch on the 10-year health plan. And I think this links to the conversations that you've had earlier on today around the ambition to provide neighbourhood-based health services going forward in a single coordinated way. A huge ambition from the government nationally, co-location, integrating working in the NHS. So it's a real left shift. We are starting to do some of that through our integrated neighbourhood teams, which are taking place. We've started considerably in Mansfield and Ashfield and Bassetlaw, about to start a rollout of this in Broxtowe next week. And the rollout is planned throughout the year in terms of bringing a range of professionals together and local communities and social prescribing link workers to really provide wraparound care about our most vulnerable patients. Our initial focus of this is really around proactive care, so for most older populations at the moment, to try and maintain their care in the community. But there's great opportunities of this if we can really significantly move that left shift into our communities and provide those services closer to home. Thank you very much.
Thank you, Fiona, for that. It was very informative, so thank you. I will open up the discussion in a second. I'm just going to jump in because I just want to clarify something. Could we go back a couple of slides, please, Catherine, to the one with the stats for, I believe, Rushcliffe? Yes. So the graph on the right, chart on the right, whatever you want to call it, I noted some parts on there: benefits, financial advice, housing and employment. Is that people coming to a primary care setting, seeking support in those areas, as opposed to that's where they've been referred to as part of social prescribing?
What tends to happen in general practice is people come with a medical condition, and as you have more of that conversation, other things come about. And what's brilliant about the social prescribing link workers is when the GP might say, actually, you're suffering from pain or you're suffering from headaches, but actually you've got potential issues with employment or home life. And so they're able then to move them into a social prescribing discussion where a care plan will be put together. And some of that care plan might be about, actually, what's causing this is really my financial circumstances. So what the social prescriber will do is link to various organisations like Citizens Advice and other organisations for advice. So, and particularly during COVID, we saw a lot of that coming through social prescribing was much more around cost of living, fuel poverty, and some of those areas. So absolutely, they see a range of things and try and signpost people to the appropriate advice.
Yeah, thank you very much for that clarity. I thought it was almost like primary care was starting to act like a bit of a pseudo citizens advice, but obviously it's not. It's the medical presentation and therefore the signposting to those. So yeah, that's great.
I think it does reflect what people are coming through the GP's doors for. And I think, you know, they are a catch-all and they see everything. And I think this really reflects on the kind of issues that people are facing when they come through the GP's doors.
I think also it's part of the problem we have with primary care at the moment is many people access primary care for reasons, for conditions where the GP can't offer that help and support. It's for other reasons on here. So chronic pain sometimes, not all the time clearly, pain syndromes, depression, anxiety, all those things that they go for a treatment at a GP for, often there can be background reasons. So the social prescribing element is actually very supportive of that.
I'll come to Councillor Wheeler first.
Yeah, thank you, Chairman. So thank you for the whole presentation. So it's something that I've been quite involved in prescribing because it's not on portfolio of the Borough Council for Health. And I've been to the hub at West Midlands many times, across West Midlands, and incorporating the work that they do there. For me, it is a important tool because you can stop some people going on medication they don't need to, being stuck that cycle, and I have to get out there. But actually, the social aspect on there and walk around potentially Rush Country Park or going runs around there or beyond cooking and work being done in the community is great and have wider benefits. I suppose for me, it's like looking at the outcomes because we have examples where people go to the gym, for example, and if they're going there with the free few weeks they've got, are they actually pushing afterwards? They just muck the old cycle, it's no longer free, or they not enjoyed it. How we're measuring the successful outcomes, perhaps not being stuck in that cycle of probably that support of primary care and secondary care. But also, I think it'd be really useful perhaps for the wider committee just to have that one information about what the county council and what the borough council and what the district council do actually prescribe. For those who has to be one part of this, which is great, and the work they do there. But we have to go to the Russian Hub and see the amount of work done there. But essentially all over subscribed, and there's a waiting list for children there. And it might be a piece of work that we can do in terms of recommendation to the county council, having about more funding can be put in there, but more why this can be done. Like I say, it does say, in my view, it saves a lot of money. Not to save money, it's actually a better outcome for a lot of people involved in social care, like I say, rather than giving medication or going to care homes or etc., which that can also replace how the huge bills that we have there. So I think that'd be one of these quite to look at and see one of the new councillors would be really useful to know that.
I don't think there's a question.
I thought there was one part of the question there was about the outcomes, see what we can see about, like I said, these outcomes and the impact that's actually having on primary and secondary care.
Yeah, so it's really interesting because in Rushcliffe, obviously, we did a pilot of this way back when, and that informed the national model for this. So that's really positive. I think the evidence is really positive on the mental health side and the social isolation side. I think studies haven't really gone long enough to see the impact on acute demand, which is obviously where we need to see the transfer of the resources. So I think there's still work to do on that evidence. I think we're seeing lots of brilliant case studies from our local schemes that are shared through our place-based partnerships about that work. I agree with your point about the county council. We've had the local area coordinators, which are working alongside that. Is there a way of kind of joining up some of that resource to do things differently? And I know there's some discussions taking place. And I think it would, we've got, great opportunities to work on this more. And obviously the funding, the NHS funding is solely at the moment through the additional roles scheme.
Yeah, just that we don't have as much evidence for primary care social prescribing at the moment, but we have really good evidence in Nottinghamshire from a basket law point of view and from a mid-knots point of view, that where we've had social prescribers in kind of ED, and they have focused on those patients who what we call high intensity use of services or high frequency use of services, that actually their service use is reduced. And so there's kind of pockets of evidence around the place in terms of the good outcomes. But I agree with you, it's about defining the outcomes we want for this population and what that would look like.
Councillor Cox.
Thank you. It's just for clarity, this, and for me personally, and there may be people listening out there, but I just want to put it into lay terms what social prescribing is, because many people might not have heard it, and I'm just going to read to you and tell me if I'm wrong in what I'm reading. Okay. Social is simple terms. Social prescribing is when a doctor or healthcare professional helps someone improve their health and well-being by connecting them to non-medical support in the community, not just giving medicine and treatment like the gym, like walking out in the green parks and so on and so forth. And I just want to put that out there because I wasn't 100% certain as what the social prescribing meant. Now I'm familiar, and I'm hopefully watching out as well.
That's very kind, that's very helpful, thank you. And I think what's interesting, we call it social prescribing, so we give it medical terminology.
Yes.
In order to get it sanctified in a way. But yes, it's a prescription, but for that sort of social alternative examples. But thank you for the clarification.
Councillor Gowland.
Thank you. I think a lot of the services that are provided by the voluntary sector, I'm thinking particularly of CAB and in West Bridgford, as I suspect these people are being sent to a financial service that's absolutely voluntary on a shoestring. They ask us for £250 for a computer now and again. To what extent are these services limited by the resources of if you're referring to? And is that something that can actively be supported? I appreciate resources are limited everywhere, but feels that maybe that's money very well spent by the county and the boroughs if they support those organisations directly. I don't think they do. I mean, just thinking of CAD particularly, but others as well.
Yeah, and that's a really challenging environment because you're absolutely right. We do make use of, the services do make use of not just voluntary sector funded services, but also community-led services by volunteers. So it is, and I've talked to a guy in West Bridgford who's running a climbing group out of his own personal resources in order to support people to do that. So you're right, it is quite a fragile environment in terms of those referrals. And I think we have seen a reduction, obviously, in that investment in the voluntary sector through the public sector, and that's something they raised through that. I think there's a few things from the ICB's perspective. So a few years ago, we introduced the Health and Equalities Innovation Investment Fund, and that has funded some voluntary sector activities since 2023. So you might be aware of the Best Years Hub across Mid-Knots, which has really made a difference in terms of supporting those people. So there has been a way in which the NHS can support that, but again, it's not hugely significant. So we do need to think carefully about the pressures that we are putting on that voluntary sector and how we work together with them. And I think part of the development of the integrated neighbourhood teams is to say they are the voluntary sector and communities are a partner around the table. How do we work together with the resources that we have in those neighbourhoods to provide those services, as Nick talked about, in terms of targeting those vulnerable populations in the best way? And we're really fortunate that we've got all our voluntary sector partners around the table, despite the environment that they find themselves in. The ICB also leads an alliance, is encouraging that BCSE Alliance development through the integrated care system. And that is a way of bringing people together and looking at opportunities for funding. But you're right, from an NHS and local government perspective, we should be doing much more in terms of working together in that environment.
Councillor Dodd.
Thank you. My area of work's up east. There's a lot of social prescribing been going on in different groups, men's in sheds, primarily for men, suffering isolation later in life, recently widowed perhaps. There's been a big uptake and it's been very successful. Another area which is quite close to me, the Oasis Community Centre, which I'm sure you'll be aware of, caters for anybody from 1 to 100. And there's great instances there of people going down and working in the green space in the garden, prescribed to go for 4 weeks and they're there 8 years later. So personally, I've seen the great success of what this can bring. I'm just curious where you actually see this in 10 years' time, because this is all fairly been born out of COVID, for want of a better word. And I'm just wondering what this social prescribing looks like and what you think it's going to look like in 10 years' time.
That's a great question, and maybe we need to regroup again later on. I think it goes back to neighbourhoods and neighbourhood focus. It goes back to targeting inequalities. It goes back to wrapping around services around our communities, those natural communities that we have in those areas. And actually, the NHS delivers the NHS aspect, but the majority of that funding would sit in the community. That's where we need to be seeing, and that's social prescribing much more led and driven by our communities and the people in them in terms of supporting that health going forward, not in the way we're doing it at the moment when most of the resources are sitting in the NHS. That would be absolutely fantastic if we can move those resources into much more community-led initiatives.
Thank you.
Councillor Barlow.
Is there sort of like an age range that we're looking at this social prescribing, or is it literally from birth to death, so to speak?
It's usually adults. The model that we have through the additional roles in the primary care network is adults. There are some examples of using this approach in children's services, but it's mostly in the adult community. And I think it's mostly to do with, I haven't got any age data on here, but a lot of it is more older population. And that, you know, I think that's interesting in itself in terms of the support that older people might need in the communities, and why are we not providing those in slightly different ways. But technically, it's an adult service.
I was just checking if there was any of the members, but if not, Guy, please.
Thank you, Chair. Big fan of social prescribing. I think it can have a lot of good outcomes for people. But I think in the paper there are some things that concerned me. One was about waiting lists and starting to think about how you triage those, and the other is about understanding how you then passport people on, because actually we could be creating other layers in the system that makes it more complicated than it needs to be. And so how do we avoid that happening? And also, how are we avoiding duplication of services? There's lots of employment services out there. How do we not take away from those employment services that are there? Again, the benefit services is the same with that. I'm not sure we're connecting into the services that are there. I don't want to be creating things just to make them under the health banner, if you like.
Yes, so the paper does touch on waiting lists. I haven't got any information, just anecdotally, because of the numbers that potentially can be seen in those services. I think it's really impressive that our services are trying to do alternative ways of seeing patients, whether that be in group sessions, using Teams and telephone and using alternatives. So they are managing that in the best way so that we're not having that huge levels of waiting time or other alternative things to be seen, areas for people to see. I think in terms of the second point, which has just gone out of my head about the was it the services? Duplication. Yeah, well, there's something before then. I might remember. But yes. So I think that's part of the telephone consultation. Really, is to see the kind of support people will need going forward. So I think that helps in terms of that signposting. I think in terms of the duplication of services, I think if we put all our budgets together, it would be a lot of money on this. And is it duplicated? And I think that's something worth looking at. I think from a primary care network perspective, obviously that's not ICB funding, that's within the primary care network. And as they're very protective of that resource because it's for their local patients. So it's about how can we use some of this resource really effectively going forward. And I think that's got to be part of the consideration when we think about neighbourhood services, how we use our joint resources to support people in those communities. Because I think you're right, we're really good in the NHS at layering on top of things. And actually, there's very little, we don't have the resources to do that. And there's some great activity happening that we need to sustain.
Any other members? Just bring anything forwards? No, I'll indulge myself then. I'm a big fan of this. I had a call with Guy yesterday, and we discussed elements of social prescribing. And I am a big fan because I'm a big fan of community and, you know, the positive aspects of community. And I think one of the questions for me is the social prescribing link workers. When the NHS first came about, the GP was that because they were a community figure. They knew everybody in the community, they knew what was out there, whereas now they're so distant from community and often not part of the community at all. So are these social prescribing link workers, are they there to fill that void and be the sort of the element of community that the GP has now lost?
I mean, my view of that is that obviously the nature of general practice has changed significantly since 1948. And I think there's lots of societal reasons for that. And I think where we are now is that, as Nick said, people are coming to the GP with lots of things they would have managed previously in other days in the home with the families. And they're coming with a range of issues. And I think one of the things that general practice is really good at is determining who needs to be seen by whom. So which professional is best to be seen for the care of that patient in order to maximise the resources that we have in those environments. So I wouldn't see it as the GP being distant. I would see it be about the range of professionals that we now have in GP practice as a result of additional roles is fantastic. My dad rang up about his prescription, got the pharmacist straight away, didn't have to wait for a GP appointment. I told him he didn't, I said, don't ask for the GP, because actually the pharmacist is the best person. So I think there's ways in which we can signpost that, but I do agree with you. I think that social prescribing link worker is providing some of that as well, but I'm not necessarily from the GP perspective, but from society's perspective and communities and families, and the differences that families are more disparate perhaps than they were when the NHS started. So I think there's lots of reasons, but I think overall it's a great addition to the general medical profession.
The reason I asked that question and what their relationship is with community is very much that I've never seen any of this, social prescribing and link workers. I had no awareness until having the privilege of being the chair of this committee and seeing this report. And you know, I go to what Councillor Dodds was alluding to. There's some really good social prescribing in Worksop East. I represent the Misterton division, which is very rural, very spread out. And we do have strong community, but we don't see any of this. And I don't see any link workers linking into our strong community assets, parish councils, sports clubs, church groups, knitting groups. So what are the link workers actually linking into? Is it more of these bloated, you know, sort of local authority or healthcare generated groups? And there's this sort of just system design of you get signposted into there, or is there a big opportunity to get right into the grassroots and get people, especially where social isolation is concerned, get them into local groups? You know, we've got some fantastic parish councils and local groups where people essentially they could get over that burden of social isolation, but 9 times out of 10 they'll probably get signposted off to a service somewhere, if you get what I mean. So is there more work to be done where they can get right into the grassroots of community?
So I think it's really variable. So if you've had a look at those links that are put in the paper, where you've got a large provider delivering that, you've got a range of large providers and quite small independent GPs delivering it on their own. So I think the variability is interesting. I think if you talk to the Rushcliffe team, they're absolutely doing that. They're absolutely in all those communities. I think perhaps if you talk to the Bassett Law, the Bassett Law CVS who run the service for 2 of the PCNs in Bassett Law, they're absolutely in those communities because they're making also the links through their voluntary sector. So I think it is a range, and I think where it's working really well, they've got those links. But I think if we got all social prescribing link workers in the room, they would say that is part of their role, is to find out exactly what is out there. We've done quite a lot of asset mapping, both for primary care networks and for the integrated neighbourhood teams, to say the wealth of things that are out there, both for the local patients and the citizens, but also for professionals as well. So I think there's an awful lot of work happening around that, and I would have real confidence that is out there. It's very interesting, your point about the Misterton area, and that could be in terms of how that social prescribing is organised up there. I think a lot of the reporting is going through our place-based partnerships. So we have 4 place-based partnerships across Nottinghamshire, and they receive updates on some of this type of work because it's related to some of the prevention work our place-based partnerships are doing. And there are often newsletters with those place-based partnerships, and I'm getting a message that we need to be getting those out a lot more. And we also obviously use the ICB's communication network to get good news stories out there. So I think it's definitely a takeaway about how we can raise the profile of some of the work that's happening, particularly if it's a smaller organisation leading it.
Thank you. I do have another question, but Councillor Wright just leaned into the opportunity.
Excuse me, do you put posters on at all?
I believe there's lots of posters. If you go on the Facebook pages, it's full of posters about the next social prescribing event happening in your area.
Thank you. They do work.
For that group, clearly.
I think for everybody.
Thank you for that. So my other question with regards to the social prescribing is very much around how we stop people needing it in the first place. You know, the old prevention's better than the cure adage. And I know Councillor Cox, he's got a lot of experience with policing and sits on the, I believe, the policing board, do you? Yeah. And you see with policing, a lot of people use police nowadays as a social service, and they're picking up the loose ends of where people aren't in the right, you know, in the right stream of support, and the police just end up picking up stuff that isn't their role. And I see with this, it's a great initiative, and you know, we should really champion it. But I think we should also be looking to the future and thinking, well, how do we stop people getting here in the first place? You know, what is the opportunity where we can start to take pressure off so that those that are in the greatest need of this care actually get it, and everybody else, you know, already invests or is invested in by the community. And like I say, I'm a strong advocate for community, and you know, I just think that there's an opportunity somewhere where we can keep people out of the NHS, if you know, not willfully, you know, those that need it, but stop using the NHS as a come one, come all, and just get the right people who need that NHS support.
I totally agree with you. If you look at the problems that people not just go to the police with, but go to healthcare providers with, many of it is things that we can't necessarily help with in a healthcare provision. It's other factors in their life that has an impact. And I totally agree with you in terms of building up communities. That is the future. That's why the models of GP practice in terms of the integrated neighbourhood teams is the way that's going. I was out in a church last week in Nottinghamshire, where very much that faith-based approach needs to be improved in terms of they want to help support their local communities. They want to understand what it is they can do differently. The only way this will work is everybody works together on the same agenda to build up those communities again. I totally agree with you.
And do you want to now? That's all right.
I see it as like the church in the community doesn't seem to be what it used to be, where people used to gather and do things, and there were spin-offs from it. Have you contacted the churches, and are they pretty good to work with, or?
So I think social prescribing link workers have got lots of contacts with lots of community groups.
Yeah.
There's actually been a lot of work done with the faith communities, and they produced a sort of a bit of their own social prescribing model that we has been showcased in Nottingham City in particular. So yes, they would be one of the groups that we work with on the range of community assets that are out there.
And have they been? Do they look pretty successful when you do that?
Well, the faith social prescribing work that's happening in Nottingham City looks really positive, and as Nick said, it's really around those communities really wanting to come together to support that, and it's a slightly different angle, and it's much more focused, I think, on families as well, which is an interesting concept as well for social prescribing.
Have you reached out to more rural areas though?
Yeah, so, well, Misterton, we need to go back and check the Misterton position, but clearly on the rural issues, absolutely. I think it goes back to that individual's care plan, where they're living, what their sort of social networks are, how they can maximise support to help them maximise those social networks.
Thank you.
Yeah. Anybody else? No? Okay, I think I'll summarise there then, Robbie. Yes, go.
Just make a final comment. Thank you, Chair. I think there's something about understanding that elected members have quite a lot of detail about their local areas. I think there's something about us understanding who those social prescribing workers are, and actually having those persons there who are linking those people right will be an opportunity to see what other things we can access through those really. So if I think that we want to make a recommendation to allow that to happen, I should agree.
So I think what I can do from here, I gave you the links to the providers. So what we'll do is we'll get a list of the leads in those providers and align it to the neighbourhoods that you work with.
Okay, so I really want to thank you for presenting the report and obviously, you know, giving your input today. Like I say, I'm a big champion of this because I think we over-prescribe sometimes. I know that a lot of closing the name with this one, prescribing, but we over-prescribe sometimes and put people into bloated services where really, you know, the holistic low-level stuff is where, you know, the big wins are. So again, I would like to, you know, keep in touch and invite you back, you know, at some point in the future to see how things are progressing in this, and obviously you can feedback on Misterton bit as well. I also note that you gave Councillor Dodd a great question, but I didn't get that, so it's just a little joke. So I will move to the recommendations now. First recommendation is that the report be noted. I agree. Report to be noted. Thank you. And the second recommendation that the feedback of members on the social prescribing model be noted. Yeah. Lovely. So that's pretty much it in terms of the agenda items for the ICB. So if you don't want to sit and listen to what we talk about on the work programme, then you are free to leave at your leisure. But thank you very much for all your input this morning. Right, we'll just move on to the last item of the agenda, which is just a look at the committee work programme. May I hand over to you, Catherine, just an update on the work programme?
Happy to, Chair. So, members, I know you will have poured over your schedule of work for the committee's scrutiny activity for this year. I know you were holding it close and reading it to those that you love, so I will not go into you know, a lot of detail, but I want to highlight to you just a couple of changes that have happened since we last met here. So the first is, you're aware that the fertility policy review did not come to this meeting, and that is because the fertility review work has paused with the ICB pending the NICE consultation on their forthcoming updated guidelines. So we will look for an appropriate time after those guidelines have come out, and they have worked on that review to bring that item back. So you will notice that in its place, we have today considered an item on system approaches to wider determinants of health and holistic approaches, which is our social prescribing item. That was in our to be scheduled and potential alternative actions group. So we actually were able to see that today. And I want to also bring to your attention that we've further added another item from our scheduled and potential alternative actions list, which is the Bassett Law provision and needs assessments item. After hearing comments from members about Ashfield, Mansfield, Bassett Law, ensuring that provision is going to these geographies, we have collaborated with Public Health, the Director of Public Health, to arrange for an item to come specifically on this topic, what the council and the wider system are doing to address geographical health inequalities. So that item will come to April. So I just wanted you to know that that will change, and that has been added. Another item that will be coming to April is the from NUH, their work streams around people in their organizational strategy will pick up what members have requested around their service culture and leadership and around how they are doing skills recruitment and retention. So those are changes that you will see coming up, Chair.
Thank you, Catherine. Have any members got any questions with regards to the work programme? No. I'll just highlight. I'll just bring a highlight forward in respect of the work programme, which was that members attended the NRC, the National Rehabilitation Centre, in Stanton on the 10th of October. And I also then attended the NRC for a stakeholder event just prior to its delayed opening. And I know that colleagues on this committee, Councillor Wheeler, in your previous role as Health Scrutiny, had a lot of involvement with this project. So it's good to see such a great facility in the county, and you know what that is aiming to deliver. I think is next level. So real highlight for the work programme. So if there's no questions, I'll move on to the recommendations. The first recommendation is that the work programme and scrutiny priorities be noted. Yeah, and that the second recommendation, the authority be delegated to the Health Scrutiny Lead to update the work programme as appropriate in consultation with the Chair, Vice Chair and representatives of the relevant partner organisations, with any changes reported to the next meeting. All in favour? Yeah. There we go. All that remains is to thank the representatives of the ICB who've already gone, and I've thanked them already, and also members and officers for attending today and contributing to what I thought was some really good probing discussions on the agenda items. So with that, I will now formally close the meeting. Thank you.
Thank you.